Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
And we're here. The doctors talking about headache.
Ooh, headache.
It has been suggested that we have segments so that people can skip
so they
ahead
know
when
where to
watch
go
after.
if they don't like this part of the
For those people who don't like who I tell
the banter.
these aren't the doctors you're looking for. Hey, we got the comments coming already, if you can believe it.
This is the banter section, I guess.
I guess so. And it's Dell and Murphy from, Dell and a Murphy. Delanda Murphy. I'm not sure, but hi, my favorite doctors. Hi, Delanda Murphy. We are glad to have you here.
Welcome.
So we will make this review comments from the audience, live audience time.
Yeah, that means get your comments in now and tell us about your headaches.
We'll come back to the comments later too. I'm sorry. Yes, I did.
You're working on the.
He's still working on the thing.
On Facebook. I was not here last week.
Tell me just to give it up.
You missed me last week, and I watched the video, and there were. You guys got a lot of super chats about me.
Super chats were
I was like,
crazy.
man, do I take that personally? I guess when I leave, that's when you guys do the super chats.
So I'm hoping to make up for it with the Gwen can.
Oh gosh, I don't need that.
The glam can. Oh, it is. I thought I adjusted it.
Are we not?
Now your head's like barely. Your chin's like resting on the bottom of the screen.
Maybe I was.
Yeah. Okay. So. We'll work on the Gwen cam. Okay, we do. Delanda Murphy has another comment here. She says,
"We don't
try
need
to have 20 or more migraines a month."
Oh,
Botox.
that's enough.
Okay, we will talk about the people who have more than 15 in a month for 3 months or more. There's something to look for. We'll get to that.
Ooh, a neurologist. That's what you look for.
Headaches. I believe that the title of the show had to do with red flags.
What did it say? I can look that up.
So we should probably address the red flags.
Can be done. Headache red flags. What is
headache red flags?
Yeah.
Do you think that the Snoop? Was it Snoop 10?
The Snoop 10 criteria. Yeah.
Do you think the Snoop 10 would kind of clue us into the red flags?
Yeah, those are that's the mnemonic. Maybe first. We should distinguish between primary and secondary headaches because a primary headache is...
To me, they're almost all secondary, but...
Yeah, but a primary one is one that, is one of those just general headaches that we... I mean, yes, technically some of these are due to other causes. That's what we mean by secondary headaches. It's secondary to something else going on. But some of these headaches, like tension headaches... the classic migraine are not secondary to a dangerous thing going on that we need to investigate.
But I would call a tension headache a secondary because it's secondary to the tension.
Yes, I technically, yeah.
Yeah.
But yeah, with the red flags are the things that would clue us in to look for, go searching further for something else causing that headache.
Absolutely. So headaches, just like any presenting chief complaint, doctors can divide it into there's metabolic causes, there's infectious causes, there's vascular causes, there's neoplasm causes, there's trauma. So a number of categories, and you can do that with headache too.
Yeah, absolutely.
And you can come up with something in each of those
categories.
But you were kind of hitting some of the major headache syndromes that we think about and worry about. But most people who experience a headache, it's something they've had before. It goes away.
Yeah, you take some Tylenol or ibuprofen, or you take a nap. And it's not persistent. It's not.
So that's
and it's
like
not
the tension headache.
I guess the other thing is accompanied by things. Now migraines can be accompanied by sometimes visual changes beforehand, but those are
Strange neurologic changes.
and sometimes strange neurologic changes, which can sometimes make us very concerned and go down the road of a workup. But typically, people who have migraines know that. They know what to look out for because it's a recurrent thing.
That's right. The first time it happens, you have to get the workup, though.
Yep. Yeah. Excuse me. So where to start? Should we do the Snoop 10? So Snoop 10 is a mnemonic to remember all of those different things to look out for. And the 10 actually is just, there's 10 P's. 10 things that start with P. So
here's the 10.
Hey, there you go.
So the Snoop 10 has 2 N's and 2 O's. A P and a 10. It's a mnemonic. So the first one is systemic symptoms.
Yeah.
Fever, weight loss. I don't know. Are there any more systemic symptoms we need to talk about besides fever?
Maybe night sweats.
If you're thinking malignancy, could be also, well, night sweats could also go with infectious if they have.
It could.
Abscess from TB.
Yeah.
But weight loss.
And weight loss, absolutely. Yeah. So systemic symptoms would point towards a more systemic process, and neoplasm is one of those, which is the N, which is the history of having a previous, malignancy or cancer.
You had cancer ever before, we always have to think,
did it go to the brain?
Could this be from the cancer that the person had in the past, and now it's showing up in the brain? That can happen decades later.
Yep.
And then the other...
And the other end is neurologic deficit. Now, a lot of these will lead us down a path to look into it further, which is usually imaging to make sure, if we're looking for metastases in the brain, we need to get a CT scan. If there's neurologic changes, or this says deficit, vision changes, garbled speech, weakness somewhere, numbness somewhere. Again, it's moving on to get an MRI typically to look at.
That's both of the ends, neoplasm history and neurologic deficit.
Yep.
And then next is...
Oh, we're moving on to the O's. Older... onset. Yeah, we haven't done older age yet.
Onset. Sudden abrupt.
A sudden or abrupt. And this is... the word thunderclap is what we learned. Yeah, it came on like that. It was so quick.
Instant onset.
And what we're looking for there is a subarachnoid hemorrhage or a bleed in the brain, often described as, quote, the worst headache of my life. That combined with a thunderclap will very quickly get you a CT scan in an ER.
Very quickly.
Yes.
All right. After that comes...
Older age. This one's great because it says 50.
Greater than 50.
50 years.
So if you're like me...
I'm not that far off.
We're worried about
knocking on the door.
We're more worried about your headache than if you're not as old as me. Okay.
And part of this is you've lived your life 50 years without headaches, and now you've got headaches. Something's changed. Something's going on there. And this is, like not your normal headache. If you've had tension headaches your whole life and you're 50 and you have your tension headache, okay. Or your migraines that are continuing into your 50s, that's not what we're talking about. These are new headaches that just started in your 50s. Whoa. We don't.
Well, you're talking, so.
Oh, okay. All right. So if you're over 50, new headache, it should be evaluated.
All right. And then after older age, the next one is pattern change.
Yeah, this was kind of what I was just talking about, that if you have this migraine that's been going on your whole life and you have another migraine and it's the exact same, we're pretty confident that's your normal migraine, or you get tension headaches, or every time during tax season you get stressed out and you are getting those tension headaches because of all that stress, and this is the same, that's a consistent pattern. However, if this is a brand new thing that came on that you've never experienced before, that is part of that.
All right, you want another P?
We'll do P's for a while here.
Give me how many P's? There's 10.
10 of them.
Well, that's why it's called Snoop 10.
Snoop P10. Yeah.
Okay, so
Snoop
the next
10.
P is positional features. Positional features.
You talked about that one, yeah.
So if you are lying down and it's there, and when you're up, it's not, that's different from one that is there the same when you're lying down or when you're sitting up.
Right.
And so then we're more concerned about
changes of pressure inside the
yeah.
brain, like a CSF leak or
if there's-
intracranial hypertension.
Now, CFS leak, now that's actually worse when you're up, right? That's why we have people lay down after we do a spinal tap. Okay,
But those
positional
are-
features. Precipitated by Valsalva/exertion. So this P means it gets worse if you
Bear down.
hold your breath and bear down. So if that's making it worse, chances are there's increased intracranial pressure with that one also.
Same thing. It increases pressure in the
And maybe bearing down is how you caused it in the first place.
for an aneurysm. Is that what you're talking about there? Yeah.
Did they say the king died on the throne? I'm not sure if that's true or not.
That's the rumor.
I think
but
they also
didn't
say it
know
about
that.
Stalin.
Say that about
And that he was in there for hours because nobody wanted to knock on the door when he was in there. And the next P, papilledema. This is not something our audience will be able to be aware of.
Oh, you missed one. Progressive symptoms.
I missed one. Progressive symptoms.
Yeah. Let's do that before. Progressive
Let's do
symptoms.
progressive.
Meaning that it is getting worse. Today is worse than yesterday, which was worse than the day before, and it is just building up the symptoms of the headache, or it's combined with symptoms that are building up too. I didn't have anything, now I have other symptoms. Now that does fit with the other
You
neurologic
described a
changes.
subacute building up, but it can also be acute.
It could
Within an hour, it's
take off.
Yeah.
Yeah.
both of those are bad.
Right.
Now papilledema.
Now papilledema. This is not something you're going to know on your own unless it's significant enough that you're getting blurry vision.
It's not something they're going to know even if they come to our office.
That's true. Papilledema is swelling of the optic disc in the back of the eye that you have to do an eye exam to look at. Which
Why am I laughing?
because we don't do these all the time with every headache. This is not something. I have other ways to look for increased pressure in the brain, which we kind of already talked about, and that's really what this would tell us. When there's increased pressure or fluid in the brain, it can show itself in the back of the eye because it's just pushing on that essentially.
So the reason I laugh is because the finding of papilledema and what it looks like, doctors all know what it looks like because we've seen pictures.
We've seen the pictures.
And maybe you've actually seen it with an ophthalmoscope. Now, ophthalmoscopes are interesting. Every medical student is made to buy
Get one.
an ophthalmoscope and to learn how to use it. Now, how many doctors
When's the last
actually
time I
use
used
an
one?
ophthalmoscope? And if somebody came in and they could have papilledema, which would help with the diagnosis, how many doctors aren't really competent to
Seeing enough that they
do it?
know that, they know what it looks like.
So the problem
It
is,
is, yeah.
the ophthalmoscope, you really need to have the eye dilated to be able to see anything. And even then, it's hard.
Yep.
And it's not something that you're doing all the time in daily practice as a family practice doctor. You just don't have time to look at every eye that comes through, or even enough to stay
And
really
it's
good at it.
And it's
to
also
tell you the
hard because we don't dilate the eye.
Yeah.
We're looking at an eye that's typically constricted and it's hard to see everything.
And this is actually something that, if you missed a diagnosis, you'd probably get grilled for not seeing that they had papilledema.
Yeah.
But the reality of practice is, if you're suspicious enough that there could be papilledema there and you need to rule it out, you're going to send them to the emergency department to get a stat CT because it's the only... You just don't trust yourself to... And even if they do have papilledema, they're going to end up getting a CT. So
Yep.
just making sure if that's something that you really think could be there, you're going to get the CT anyway. And that's just the reality of... And so that's why I've got a bit of a problem with we make every medical student go through this process.
Yeah.
Buy that. It's expensive when you're a medical
It's
student.
Allen. They got their claws.
Oh
in the-
my
in
goodness!
the
Those
medical
reps
schools.
come and they have the equipment days, and they sell you this thing, and they tell you need the fancy one with
The Panoptic, which I bought. But
Yeah, I think I saved Kara from buying one. I don't know. She may have bought a Panoptic.
Oh man,
Actually, I'm sorry. We may have bought
for her. Yeah.
Our office has one fancy ophthalmoscope.
Yes.
And
I think mine's still at home.
I've looked
I should
through
bring
it.
it in. Yeah.
no, we don't need
On
it.
occasion.
I've kind of taken them out of all. I didn't buy ophthalmoscopes for all the rooms. A medical supply rep gave us the ones we have in rooms.
I use them on pediatric patients for the red reflex. That's like
red reflex. Okay, that's a very basic thing. That
it is.
You really don't need an ophthalmoscope to achieve, but
yeah,
you can probably do it with an otoscope.
if you're
So that's that thing that's hanging in the wall. The doctor looks, and maybe you have a doctor who actually looks
clicky thing
through it at your eye. Good for that doctor. Because how many patients has it made the difference for that they keep up that skill?
In my outpatient practice, none. Yeah, I can't think of any.
So your people who go into ophthalmology, not opticians. Well, maybe opticians, optometrists. That's what I was trying to come up with. They would use them. Maybe some others. Maybe neuro. Maybe.
Yeah.
No, that's about it. ENT wouldn't even use it.
Nope.
Okay, moving on. That was my little soapbox about making students buy ophthalmoscopes.
Buy all those, yeah.
Yeah, so we said precipitated by
we're on pregnancy.
Pregnancy or just had a baby.
Or postpartum, yeah. Preeclampsia is a big thing that comes to mind for that, which is a
venous sinus thrombosis.
Yes, yeah, that's a good one too, yeah. But there are so many things in pregnancy that can give you a headache.
Yeah, really.
So it is something that is serious that should be evaluated. Yeah, and typically, I mean, the other thing is deciding whether or not to get imaging. Now that is up to your OB-GYN, and they have a lot of experience with it to know when and when not to. But yeah, a headache during pregnancy can be worrisome.
The super chat worthy term I just used, venous sinus thrombosis.
Ooh, yeah.
There are these drainage areas after blood is done its thing in the brain, it's going back in the veins to go back to the heart. There's these cisterns inside of the skull that blood collects in, and if it gets clotted, bad things happen for brain circulation, and so that's what a venous sinus thrombosis is. Painful eye. Autonomic features. What are autonomic features? There's a reason that autonomic sounds a lot like and looks a lot like automatic.
Yep.
It's because they're things that happen without you making them happen. So this would be like sweating,
eye constriction here.
Eye constriction, digestion.
Yeah.
These are things that are controlled by the autonomic nervous system, and there's two parts to it. There's the
heart rate,
rest and digest, and there's the fight or flight part of the autonomic. See, they happen automatically. Rest and digest, fight or flight, to be ready for fight or flight. So if
I do both at the same time.
If you're having
rest and digest while I fight.
While you're fighting, eating a sandwich. Wow. So if you have features like that with something going on with the eye.
Yeah. So
with a headache,
the big thing is reactivity. So when a light is shined into your eye, it should constrict because it is decreasing the amount of light into the eye. Now, that being said, the opposite eye should also constrict. So we're testing both afferent and efferent nerves, for nerves that go back to the brain and from the brain back to the eye there. So we do that. Yeah, we do that on both sides to make sure that you're getting nice normal constriction of the eye.
I do it with an otoscope.
I do too. That's I just shut out like people got these cool like pen lights. No, I abandoned that long ago. There's an otoscope right there. I'll shine that in your eye.
I use it for everything.
Yep.
I use it for looking at skin lesions. All right.
I was thinking you use it for everything, like a knee hammer. You're using an otoscope.
It'd work for that. It actually would.
It would.
All you need is an otoscope.
I actually use my stethoscope as a knee hammer. It works great. And that works too. You got a built-in one with your hand.
Do it with my fingers. I'm that good. Okay. Post-traumatic.
Oh yeah. If you're in a car accident and have a headache, you're getting a CT scan because you may be bleeding.
Another P is pathology of immune system. Okay.
HIV.
All right. I guess that would be that. And
the
autoimmune.
Yeah, and what they're looking for is opportunistic infections there, right? So
What about
skids?
arteritis?
Temporal arteritis?
Temporal arteritis. Would that also be considered pathology of the immune system?
I mean, that's
inflammation of your artery. If it's tender when we push right on your temporal artery, that's where it hurts. Okay, then we're going to start you on some prednisone.
Yeah.
And then ask questions.
Get a biopsy. Yeah. Prednisone first, questions later. But I think the big thing you're looking for here is if you have a immune system problem, you're on chemotherapy, you've got HIV that's uncontrolled and moving into AIDS. You are
on TB again.
Yep. You have certain other medical conditions that deplete your immune system that can set you up for certain opportunistic infections, and some of those actually can infect the brain and give you meningitis.
Yeah, who had an abscess in his brain?
Brain abscess.
Worm.
Oh yeah, that's right.
Brain-eating amoebas from.
Yeah. Oh yeah, Naegleria fowleri.
Oh my goodness, he remembers the name.
Oh man,
wow.
You know why I know that name? Because my son got obsessed with that and just went out learning about Naegleria fowleri. I was you're right.
I've never seen a case.
Yeah, they're exceedingly rare. I think in maybe 60 over the past 50 years or something. It's like less than 10 a year or something.
And then the last one is painkiller overuse.
Oh,
Rose, we want to talk to you about this one.
Rose?
That's her name.
Oh, okay. Taking too much painkillers can unfortunately mask scary things, and also coming off of that can kind of make things as well.
When it says painkillers, it doesn't mean just controlled substances or opiates. This can be acetaminophen, Tylenol,
coming off of those
over-the-counter pain relievers that we use also can do this. And so that's what you think of when somebody's having that. Oh yeah, I have a headache. More, 15 days out of the month and been going on for a while. You got to check to see, could they be in a cycle of you take the medicine for your headache so often that when you don't take it,
you're getting a withdrawal
headache. You have a headache.
Yeah. And that's actually very common with migraine medications, the abortive migraine medications.
Yes, anything we treat a headache with.
Pretty much, yeah, you can get a withdrawal headache. Caffeine.
So the way to address it is to
drink coffee.
Try to take a break from one of the pain medicines and then instead of taking all of them every time,
which is the hard
rotate over time, not take any single one for any more than 3 to 5 days, and then
Hey, we got through all the P's.
We got through all
10 of them.
I'm sorry, we have comments
now. Let's get back to your comments.
Section
3.
Oh my goodness! Look what Laura Barzyk did. Oh my goodness, Laura!
Thank you.
Wow.
All right.
Woo-hoo. Thank you for the Dutch.
Drink to that.
The idea of the Dutch is that
so we don't get a headache.
Caffeine withdrawal. There you go. The idea is that it should make us more entertaining. So thank you, Laura. I hope that helps. Wow.
We think we're more funny, at least. When
I laugh at me more when
I'm hilarious.
Wow. We're going to be talking about headaches, but let's get through the chat. We got. This is Rose again. I've had mine since my head went through a car window. I don't know how many times I've had that thing in my head from my neurologist. And then Lindsay.
Trauma is one that we talked about.
Husband has severe headache. I didn't know that. They can be triggered by not eating. I've had that one. The hangry headache.
Yeah, that can help.
He develops a headache. I ask if he's eaten. No. I have a deep sigh.
This sounds relatable.
Yes. Hypoglycemia.
Right.
Can cause.
Yes, it can.
That would be a metabolic
one of those symptoms.
We were talking earlier about that. We've been having the same conversation for 14 years. we know how this goes. And then we get a hello from Minitron.
Hello.
Lindsay. Blood Sister. Great band name.
Blood Sister. What's the name of your band? Blood Cistern.
I'm sorry, what was it again?
What are you looking for?
Venous sinus thrombosis, yes. There's
Cerebral
also something actually,
venous thrombosis.
what's actually called a cistern, though? Isn't there something that's actually called cistern?
Yeah. But, the sinus, is it called the cistern? I don't know.
This is embarrassing. I can't come up with anatomic terms, and I'm a doctor. Okay, Brenda's first questions later. She loves that. Take That's
right.
Yes, it truly is a thing. Okay, so this is pretty awesome. Laura Barzyk,
Yeah, thank you.
That Dutch all around. She's getting
on the house. Well, no, it's not on the house. It's on Laura.
It's on Laura. Thank you, Laura. That's pretty cool. We're very pleased with that. So what is it that we, other than any comments that may come through here yet, what is it that we need to make sure we say about headaches? You know, the red flag symptoms. We kind of went through the Snoop 10, which is features, not necessarily red flags. So we talked about if it's sudden in onset, if it's associated with fever. Also, we have a term called nuchal rigidity that is sometimes talked about with the term stiff neck. And no, everybody's had a stiff neck. Very few people have nuchal rigidity. So imagine a neck so rigid that, first of all, the patient's so out of it that you can do this and they don't resist you. You put your hand under their head. That
itself is concerning.
Yeah. Yeah, mental status changes. Under their head and lift. And instead of their neck flexing, the whole body's coming off the tip. That's nuchal rigidity. That's something different than a stiff neck. So if you have that, if it's associated with like fever and sweats, we're thinking
you're getting an LP quick.
Meningitis. If it's associated with the thunderclap headache, we're thinking of bleed in the brain and irritation of the lining of the brain called the meninges. Which would be a non-infectious meningitis, I guess.
Right.
An inflammation.
Yeah. The neurologic changes are a big one. Like everyone comes in and says, well, not everyone, but their big concern, the big concern is, do I have something going on with my brain?
Not a tumor.
Yeah. And if there is a lesion or growth in your brain that is large enough to cause pain, it is typically in a place where it's going to cause other symptoms as well. Now, if it's close to one of those tracks where the cerebral spinal fluid flows, then that can give you that postural headache and changes. But if it's in another place, like in the brain, typically you're going to get other symptoms, neurologic changes.
They can grow really slowly though, so the brain.
It can be very subtle, but once you develop pain, typally you're having other things with it as well.
Yeah. So if you're like waking up with a headache and as the day goes, it goes away.
Yeah. Any headache that you wake up with and
it's been going on for a while.
Should be evaluated further.
And chances are it's not going to be gone some days.
Yeah. Right.
Yeah. I don't want to worry everybody who woke up with a headache. You can wake up with a headache and it's not something bad too.
Right.
Which means we need to have some kind of a disclaimer that even though we have that marking on our YouTube channel that we are doctors, medical professionals, we may not be yours. So,
yes, you should
check with your doctor.
Check with your doctor. Yeah. If you have a headache, get it evaluated.
Yeah.
Your doctor can let you know if
don't not get it evaluated because of something we said.
Right.
This is just general interest. We're not treating a specific person.
Right.
Okay. Anything else? Other than thanking Laura Barzyk for that and mentioning Lindsay Antwine. Oh, also, Laura Barzyk, Lindsay Antwine, they should know your names are going to start appearing after some of the videos on the Dr. Vaughn channel on YouTube also. Because I consider both of them to go together and want to include everybody with everything.
Excellent.
Yeah. That's it.
I don't think I have anything else to add.
Okay. So, thank you so much for watching. Thank you for the super chat. Thank you, Lindsay Antwine. Thank you, Rose, for your comments. And we hope your headaches get better.
Yeah.
Until next time.
Yeah. Hey, I'm Dr. Wayne Baugh.
Dr. Mark Vaughn telling you to stay in good health.